This evening, I'm going to talk about dementia. And dementia is something which has historically been something we're all afraid of, and it's very tempting to turn away. And one of the things which has damaged various bits of medicine over the last few decades is when people turned away. It damaged cancer, and it damaged stroke, which we talked about last time I was here. Therefore, it's extremely encouraging, I think, that people are starting to talk much more seriously about dementia in ordinary life. And I'm just taking 3 examples from the last few years. The book Elizabeth is Missing, and the 2 films Mr. Holmes and Still Alice, which each one of which represents in turn vascular dementia, late onset dementia, and early onset dementia. Very sympathetic portraits. We also all know that dementia can affect anyone, including people with the sharpest of minds and the best of memories. I've illustrated this with 3 politicians. You may not agree with their politics, but I think no one would doubt that they were people with extraordinary mental capacity, and their families had the courage to say, and they had the courage to say, when they started to have dementia, and that they were living with dementia in the last years of their life. In this lecture, we're going to consider several bits of dementia, including several areas where I think there are often misunderstandings about dementia in the popular press and therefore in general discussions. I'm going to talk a bit about the epidemiology of dementia, how common it is. I'm going to talk then, because I think it's easy to be very negative about some of the many dementias where historically we have won or currently we are winning, because there are several. I'm going to talk about how different dementias affect the brain, and then I'm going to talk about the major dementias of old age, because this is a series about medicine at the extremes of life, a bit about living with dementia, and then at the end, a few slides talking about the future. Now, I've shown this slide before with a slightly different emphasis, but what it shows is the 10 leading causes of deaths in females. The numbers are slightly different in men, but not for the purposes of making this point. And in very many of the diseases, which historically have been seen as largely incurable or very difficult to manage diseases, we have seen stunning progress over the last few decades. So in the last decade, we have, for example, seen extraordinary reductions in cardiovascular disease, particularly heart disease, and stroke, which we've talked about in the last 2 lectures. There have been some areas where things have got better more slowly, but where the improvement is accelerating rapidly, and many of those are in the cancers, which I'll be talking about in the first 2 lectures of next year's talk. So in all of these areas, stunning progress viewed over decadal timeframes. And if you look at this, you would say the area we're losing is in dementia. Dementia rates have actually gone up because people are not dying of other things before they get there. Now, if you look at the future projections of dementia, the numbers of people living with dementia here in the UK are already substantial. So a bit over 800,000 people are currently living with dementia. And if you look forward, the projections, and these are consensus projections, are for a substantial increase over the next 2 decades, essentially because people are living longer and not dying of other causes. So everybody accepts that dementia at the moment is inexorably rising. Of course, it varies enormously by age, and this is the reason it's going to increase. And I put here the UK data, consensus data again, slight variations between different studies, looking at the prevalence, how common dementia is at different age groups. And I'd like to make 2 points with this, and possibly 3, the third one which I'll come on to and show graphically. The first of which is that even at the oldest ages, 95 or over, the majority of people do not have dementia. At very high ages. And secondly, that at relatively young old age, dementia is actually very rare. It moves up sharply once we get up to the late 80s and beyond, But even there, as I say, it is a minority of people, not the majority, which is, I think, is an impression you can often get if you read some of the more lurid headlines on the subject. Also, important to note is that the majority of the dementia there is actually mild. So those with severe dementia, which is what I think people have in their mind normally, are actually a minority of this minority. So that's the first general point I wanted to make. Second point is I think people think that because the numbers are going up, this means dementia is getting more common. Actually, not so. The best study that's been done here in the UK recently had some of its best data actually came out 2 weeks ago, but this is a slightly earlier version of those data. I'll show the later one in a second. And what it shows is in relatively identical studies done in the same places, Newcastle, Cambridge and Nottingham, 20 years apart, the amount of dementia decreased over that period by just over 20%. Age for age. So dementia is going up because people are getting older, but actually at the same age, dementia is in fact, looks as if it is going down. But there's a but in that sentence. And it's a but that is important for half of this audience. Up to old age, the difference between men and women in terms of dementia is relatively small. But as you get to very old age, by which I'm meaning really late 80s and beyond, women start to be affected by dementia quite significantly more than men of the same age. And if you look at the change in dementia there has been in the UK, assuming the data that have come out recently, and this is from 2 weeks ago, these data in Nature Communications, if you look at the change in dementia in the last 20 years, in fact what it is a substantial reduction in dementia in men and a very, very modest, probably non-significant change in dementia in women. So things are looking a lot better for men with dementia in the UK, but not for women at this point in time. And I'll come on a bit later to why this might be. But I think it's important to remember with dementia, and this is the next 2 points I want to make about dementia, is firstly that dementia is not one thing. People think of dementia as a single disease, Alzheimer's. It is not. It is many diseases. And secondly, that with dementia, it's all going the wrong way. And I'm going to highlight this with several dementias where, in fact, we have got on top of the dementia almost completely, or to a very large extent. And let me start off, as we're in Gresham College, with a disease that exploded during Sir Thomas Gresham's lifetime and actually arrived in the UK almost exactly 100 years before this college was formed, syphilis. Syphilis spread so rapidly that it was a very common disease within 100 years of arriving in the UK and stayed common until around a century ago. So the Royal Commission of 1916, which most people think is broadly right, estimated that no less than 10% of the population of London had syphilis a century ago. Just look around the audience. That's what you would have faced 100 years ago. And 7% of those went on to get a form of dementia called general paralysis of the insane that was a major part of the business of hospitals and mental hospitals of that era, if you read medical textbooks from that time. This disease has virtually completely disappeared in Western countries, in richer countries, and is disappearing rapidly in poorer countries, and the reason is antibiotics. Within the lifetime of this audience, a new viral form of dementia, because syphilis is a bacterial form of dementia, took off, HIV/AIDS. And I remember as a young junior doctor caring for people who were my age, in their 20s, with significant dementia because they had end-stage AIDS disease. It affected 20 to 30% of people in the later stages of that disease. With the advent of antiretroviral drugs, the drugs which prevent AIDS in people who got HIV, this has gone down to around 2% in the last couple of decades. And because I want to show this as a very wide-ranging disease, here is onto a parasitic disease. This is a disease that I and Professor Cox have actually at various points worked on, sleeping sickness. Sleeping sickness is a form of dementia caused by a parasite injected by tsetse flies, which was extremely common in large parts of Africa. And there were parts of the Congo, for example, where 50% of people had the disease. We're now down to a situation by a combination of methods to get rid of the fly and stop it interacting with humans, and better drugs, because the older drugs for sleeping sickness killed 5% of the people they were given to. Not a great drug. We're now down to less than 10,000 cases for the first time, really, probably in recorded history. And there is a realistic chance that we could eliminate or near eliminate this disease, which has caused dementia in Africa for all time in our lifetimes. And finally, on the infections, the UK was the place where the last major cause of dementia that was infectious actually arose. And that was the BSE in cattle, which was a prion, it's a kind of infectious protein, that jumped the species barrier and was able to cause cases of variant CJD disease, which is another form of dementia. By a combination of removing the neurological tissues that were in the food chain and by culling infected animals, we were able to get rid of this from the cattle stock in the UK, and therefore new infections appear completely to have stopped, although tragically, because in a few cases the disease is relatively slow to present, a few cases are still presenting, but the infections have now stopped. So here we have 4 infectious causes of dementia where disease has almost completely or has completely disappeared as a risk. And it's not just infections. There were, for example, many industries that used chemicals which themselves cause dementia, and there's one that virtually every child in the UK knows about, and that is mercury poisoning, which used to be a serious risk for people in the hatting trade, because mercury was used in making felt, from which the character of the Mad Hatter arose. But other heavy metals can also cause dementias. And it's not just things going into you, it can be a lack of things as well. The most recent nutritional epidemic of dementia was something which hit the USA. Pellagra, which is, and most of these are vitamin B types, was caused by a deficiency of vitamin B3 in people whose main diet was maize, or as it would be called in the US, corn, and molasses. So they lacked this vitamin, and there was a huge epidemic of pellagra, which is the disease which causes this, and pellagra causes the combination of diarrhea, dementia, dermatitis, which is this skin condition, and death. So a big epidemic of this caused by nutritional deficiency. Here in London, from time to time, people develop dementia, particularly who are alcohol abusers, because they lack another vitamin that's important in memory, vitamin B1, something called Korsakoff syndrome. And there's some controversy about whether vitamin B12 and folate, 2 other B vitamins, are also important in memory. So here we've got infections of various sorts, poisons of various sorts, and nutritional deficiencies of various sorts, all of which we can just deal with. And these have all at different times been serious causes of dementia. Before I move on to the older age dementias, which is what the majority of this talk is going to be about, it's also important to acknowledge that there are some rare but important causes of early dementia. And most of these are associated with genetic abnormalities or genetic inheritance. And 3, which I'm just going to highlight because there's very strong genetic linkage. Children who are born with Down syndrome are now fortunately surviving with often very good lives for much longer than they used to, but they get dementia at a much earlier age than other children of the same age group. And 2 dementias which are inherited is what's called autosomally dominant, which means that half the children of affected parents will get them, are the very rare diseases Huntington's disease, which causes dementia usually in the 50s, and familial early onset Alzheimer's, which is a very rare form of Alzheimer's affecting less than 1,000 known families in the entire world. But these are very specific forms of dementia which cause early disease. And the film Just Alice, so that's Still Alice, it is about one of the people who had an early onset dementia. So I hope you are convinced that dementia is absolutely not just one disease. And in fact, the dementias of old age are also not just one disease. It has many causes, but in our society, in a rich Western society, only a few of them are now common. Now, dementia has a number of things which are common to all the different dementias, and they're very different from a stroke, which is the thing that we talked about last time I was here. Unlike stroke, which is sudden in onset, dementias are very insidious. They come on people very gradually. And in stroke, what you tend to get is a very discrete part of the brain affected catastrophically, but the rest of the brain is largely unaffected. In dementias, it is a much more widespread process that occurs, and it usually occurs over many years before people show their first symptoms. Memory is affected in most people with dementia, but not all. And I think there is often an assumption that loss of memory and dementia are the same thing. As I'll go on to talk about, some people will have reduced memory that's nothing to do with dementia, and many people who have dementia will have memory loss as a very late feature. So it's not the initial presenting feature of the disease. And it is likely that over my lifetime and that of all of you, some of the dementias we talk of as one disease will actually probably be found out to be several different diseases with different treatments. And that, I think, is going to be very important in the way we think about it. Now, before I go on to talk about the dementias of old age, I just want to do just a few slides talking about the brain and memory, because I think that makes it easier to understand how dementias affect things. Last time when I was here, I talked about the fact that there are certain areas of the brain that are particularly affected by stroke, and depending where the stroke is, people will have different problems as a result of the stroke they've had. The same is true of dementia. And I want to just highlight 3 areas of the brain which are very important and which different dementias affect. The first is the frontal lobe, which is, as the name implies, at the front of your head. And the frontal lobe is the area which is largely involved in, among many other things, planning, judgment, attention span, and inhibition. Inhibition meaning stopping you doing silly things you otherwise might be tempted to do, like dance in Piccadilly Circus when sober. So the frontal lobe has a very important set of functions, and some dementias first affect the frontal lobe. Then the second area to highlight is the parietal lobe, which is this area up here in light blue. And this in particular concentrates in the brain on speech, visual integration, perception of space, and attention. So dementias that start here are likely to have early effects on things like word finding. And then you've got the temporal lobe, which is the one in dark blue here, and that tends to be involved in auditory processing and, in some situations, facial recognition and language recognition. So different bits of the brain do different things, and as a result, where the dementia starts will have different implications. Memory, unfortunately, is an extraordinary, which is a large part of dementia, is an extraordinarily complicated subject. And I want to stress at this point, partly for my professional colleagues who may be listening to this and wincing, but also for all of you, that the science I'm going to be talking about now for the rest of this is not what I consider to be settled science. This is our best understanding of memory and dementia at this point in time. But I'm very confident, and hopefully confident, that someone giving a lecture on dementia in Gresham College in 20 years would give quite different interpretations of several of the things I'm about to say, because the science will have moved on. That contrasts with many of the things I've talked about in previous talks, where in my view the science is essentially settled science. This is not settled science. Now, there are various theories about how memory works, but they have certain things in common. In broad terms, you have short-term memory and you have long-term memory, and they are probably physically located in different parts of your brain. Short-term memory is the kind of thing which allows you to remember a phone number, for example, but one that you're not going to use again. Long-term memory is the thing which is laid down and which you can retrieve, which is helpful to you in future life for a whole variety of different ways. And there are many different forms of long-term memory. And I could give an entire talk for Gresham College on memory and different theories of memory. This is not the evening to do that. But I wanted to be clear that there are many different areas of it. And within it, memory, there's what's known as explicit memory and implicit memory. And implicit memory is, for example, your ability to do things like tie your shoelaces or ride a bike. There are certain things you don't need to recall, you can just do them. You've learnt them, they're memory tricks, whereas there are other things like remembering what you had for breakfast, which actually you physically have to recall from your mind. But within those, there are many different subdivisions. So memory is a very complicated subject, and the more you look at it, rather like the Cheshire Cat, the more it disappears. We do know that certain structures of the brain are very important for memory, and the one in particular I'd like to highlight is an area called the hippocampus, so named because apparently it looks like a seahorse, so I think you have to sculpt it quite carefully to make that happen. Now, a surprisingly large amount of what we know about the hippocampus was from one patient who had his hippocampus removed to stop uncontrollable epilepsy. So I want to put a big caveat on that, but it does look as though the hippocampus is very important for the laying down and then retrieving of memories for longer term. And the reason I'm stressing the hippocampus is this is an area of the brain which is very important, it would appear, in Alzheimer's disease. But certainly other bits of the brain are also very important, and memory functions in the brain are scattered in very many areas. It looks as if working memory, the very short-term memory, is probably largely or wholly in the frontal lobes, for example. But the parietal and temporal lobes, the middle areas, also have some specialist memory functions, including for things like faces and for words. But not all memory is about physical things. And I think this is an encouraging thing to remember when you're teaching your children and grandchildren tricks. There appears to be a fairly good association between memory, intellectual ability in young life, education, and having delayed onset of dementia. And I'm just going to take two examples of many different studies that have looked at this, all of which support one another, in my view. And it's the idea that you can build up in early life, including in childhood, cognitive reserve. The first of which is comparing people who've had more than 10 years of education and less than 10 years of education, but who otherwise appear similar. And what you can see is this is age at death and when dementia came on. And what you can see is that over time, there is a rightward shift. There's a later development of Alzheimer's or other dementias in people who had more education. And there does appear from some studies, and one of the most best-known ones is a study of children from Scotland from the early part of the last century, and they were followed through their entire life, and their abilities at school predicted to a fair degree, not in individual cases, but overall, how late it was they would get dementia. So this does imply that intellectual reserves in early life and through life actually are protective. Now, before I move on to the actual dementias, I think it's important also to stress that memory becomes less sharp in age in all of us, what the Americans call senior moments. Most people who have them do not have dementia, although obviously they could be a prelude to dementia, and two very often common things which happen to people in late old age is knowing the temporal order in which they learned information, so they can't quite remember which order. They know the information, they just can't remember in which order they had it, and what's called prospective memory, remembering to perform an act at a future time. Some of you may even have had that experience. These things are not dementias, and they're usually possible fairly straightforwardly to get work around, for example, with diaries. So that is slight difficulty with memory in these kind of ways does not spell dementia. Now, moving on to the major dementias of old age, in the UK at this point in time, there are broadly 3 major classes of dementia, but there are many others which I'm not going to go through, but I'm going to talk about the 3 broad ones. The first one is Alzheimer's disease. This is the largest group, and probably consensus at this moment in time is around 60% of dementias in the UK are due to Alzheimer's disease. Then there is vascular dementia, and I'll go through each of these groups, and it's probably somewhere between 15 and 20% of cases of dementia in the UK are due to vascular dementia, which is a different dementia. The third group I'm going to talk about, and there are other ones I won't, is what is called dementia with Lewy bodies, much less well known, and this is on a spectrum between Alzheimer's disease at the one end and Parkinson's disease on the other end. But Lewy body dementia is between those and behaves quite differently, particularly in the early stages of the disease. And then finally, mixed dementia, which is a mixture, some combination of more than one of these. And then there are other rarer ones, which I won't talk about. And let's start off with vascular dementia. And I'm starting with vascular dementia because we talked last time about stroke, and this naturally follows from that. There are several things which can cause a vascular dementia, but what they have in common is that an area of the brain becomes starved of oxygen because of problems with the arteries or the tiny arteries that lead to the brain, and as a result of that they die, and this causes a dementia. That, in simple terms, is what a vascular dementia is. And there are 3 broad groups of vascular dementia. The first one is some people develop a vascular dementia after a major stroke. So they have a stroke, and then relatively shortly after that, usually 2 or 3 months, they start to develop some signs of dementia, which then can stabilise. But they're a result of a stroke. At the other extreme is when people have what's called small vessel or subcortical dementia. It's got various other names. But this is when the tiny blood vessels going to bits of the brain narrow, get furred up, stop working properly. So this is widely distributed through the tiny arterioles that lead into the parts of the brain. And between those two, and now probably thought to be less common than we used to think it was, what's called multi-infarct dementia, when people have lots of tiny strokes, no one of which causes a big stroke that people notice, but the combined effect of which is to damage the brain in a kind of pepper pot kind of way. Now, all of these can cause significant dementia. Now, the thing with the vascular dementias is which of the symptoms of dementia you first get depend on where the strokes or the vascular problems are. If, and they often are, they start in the frontal areas, then planning and behavioural issues may be the major problems that people first notice in themselves or in their partners or their parents or grandparents. If, on the other hand, it was in the temporal parietal lobe, memory might be affected rather earlier. So unlike Alzheimer's disease, the first sign of dementia may not be significant memory loss. It may be other forms of higher mental function. Now, I think there's some good news and some moderate news with vascular dementia. The good news is that we know, essentially through logic, what is likely to be good for vascular dementia, because we know what reduces stroke. We have really good evidence on this. Unfortunately, the evidence for dementia, and I'll come on to why this is towards the end of this talk, is rather less good. But it seems highly likely, and there is moderately good evidence to support this, that stopping smoking, reducing hypertension, both in the population and in individuals, finding people who've got atrial fibrillation, an abnormal rhythm of the heart, and then giving them blood thinning drugs, and exercise, and possibly reducing cholesterol and possibly reducing alcohol, will stave off vascular dementia. Now, you don't need to be as extreme as this remarkable lady, running marathons at 92. Exercise, even a few hours walking a week, does appear to be associated with reduced risk of various dementias. And I think the thing about stroke, and the vascular dementias are likely to be similar to this, is the rates of stroke have been steadily but really impressively decreasing over the last 2 decades. through a combination of public health measures and better treatment. And it is very likely that some of the improvement in dementia we've seen over the last 20 years rather, is going to be reductions in vascular dementia. And that's actually one of the reasons, in my view, that it's likely that men have had a better time of it than women, because men started off with more vascular risks, particularly smoking, and that improvement has been much more rapid in men. The one that everyone knows about, however, is Alzheimer's dementia. And it is the most common dementia in high-income countries. It was first described in 1906, including, impressively, by Dr. Alzheimer, the cell damage, which is the main thing that people know about it in terms of its pathology. There are at least 50 million cases worldwide, and that is going to rise. And it's going to rise everywhere because other diseases are going down. In the great majority of cases, Alzheimer's disease does start with memory loss. And then it can, over many years, in most cases, several years in others, progress to widespread brain damage and dysfunction. Now, our current understanding of this, and I want to stress the word current, is that Alzheimer's disease starts off with damage near the hippocampus, which is this area which is very important for laying down and retrieving memories. So memory is affected early, and it then gradually spreads over years to other parts of the brain till multiple areas of the brain are affected. But this is a slow process. We do know some things that definitely happen in Alzheimer's disease. We know, for example, that there are areas of plaques of clumps of protein called amyloid beta, and these accumulate, and most people think that the accumulation of this protein is one of the things, or the thing, which kills cells in the brain. But that is not certain, and that's an important caveat, which I'll come back to. We know that there are tangles of protein, called tau protein, which build up in Alzheimer's cells, and again, these may be associated with cell death. But both of these are normally occurring proteins. Everybody's got them. It's a gradual build-up, and what we don't actually know for sure is this just a marker of disease, or is this the cause of disease? Currently, we think it probably is part of or the cause of disease, but that understanding may be wrong. Certainly it is the case, however, that if you do scans of people and look for amyloid build-up in the brain, there is an association between amyloid build-up in the brain of people who've got early dementias and them going on to progress to have significant Alzheimer's disease. So this does tend to support the idea that at least having it is a strong marker of the potential of having Alzheimer's disease. And it may be, in due course, this will be useful to help identify who would benefit from particular drug targets. So these kind of imaging methods may turn out to be extremely important, I think, in the longer term. But, and there's a big but to this, looking at age and amyloid, if you take young people who die early with Alzheimer's disease, there is a very clear association between dementia and having plaques in the brain. So people who have plaques in the brain have a lot of dementia, or people who've got dementia have a lot of plaques in the brain. Young old people who don't have plaques in the brain do not have dementia. So in early Alzheimer's, early older Alzheimer's, the association with plaques in the brain seems very strong. By the time you get to people in their late 90s, the association seems to go away. So this may only be important for the kind of Alzheimer's that we get in the sort of 70s and 80s, and less so for later on. And the same is true for the tangles I was talking about. Now, what can we actually do about dementia? Well, let's start off with drugs. Currently, there are drugs which can be given to people who have Alzheimer's, but it is important to stress two things about them. They only work in a roughly half people, series vary slightly, and what they do is they improve memory for a while, and then it starts to get worse again. What they do is they improve the symptoms, but they do not treat the underlying disease. And there are broadly two classes of these that do this, one of which is one which helps build up a chemical, neurochemical that helps signal in the brain called acetylcholine. And that chemical goes down in people with Alzheimer's. If you give them the drug, it goes up, and their memory seems to improve a bit for a while. And the other has a completely different mechanism of action and is trying to go at the glutamate pathway, which is that's less widely used in the UK. But those drugs I don't want to dwell on because it is clear they are not curing Alzheimer's and they're not slowing Alzheimer's, they're simply reducing the symptoms. The real target for us has to be to find drugs which are going to halt, slow, halt, and even potentially reverse Alzheimer's. And you may wonder why it is that such an important disease has got so few drug targets at the moment. And I'm going to give a few reasons why that's the case. The first one is that whereas with many diseases, it is relatively easy to say when the disease starts or to actually diagnose it, and it's relatively easy to say what the end point is. So, for example, a drug which actually you're using to stop people dying of heart attack, you can tell they got a heart attack because you can just do an ECG. It's very straightforward, and you can tell if they've died because they've died. So it's relatively straightforward to tell whether drugs are working or not. Drugs which are actually, with Alzheimer's disease and other dementias, the beginning is very difficult to be absolutely clear about, and the disease progresses slowly and is different in different people, and the endpoints are much less hard. So this makes it a tougher thing just to know if we're running at all. The biology is much less well understood for Alzheimer's disease than, for example, for many of the cancers I'll be talking about next term. Although, and it's an important although, many of the most important drugs that we all take from time to time, we never knew how they worked until we worked out they did work. We tried them out, they did work, and then we subsequently worked out why they worked. So it is important to understand you can actually get good drugs without having to understand the biology. But that's going to be a lot harder for dementia because dementia is so insidious. So it's less easy to see that someone's taken a drug for another reason and then amazingly something has happened and their dementia appears to have slowed down. You really need to be looking for it. So it's tougher. We do have an animal model in the mouse in particular, but it's not really clear how good a model of human disease that is. And drug companies, and I'll come on to this in more detail, have been deterred by several very costly failures. If you look at drug companies' investment in this, so this is private sector investment in Alzheimer's, they would all love to have a drug for Alzheimer's. Clearly, a drug company that has an excellent drug for Alzheimer's is going to be a good one to invest in. But the number of drugs going through clinical trials is very thin compared to, let's say, cancers or heart disease, because this is difficult. And if you look at the history, these are just funnels looking at the preclinical drugs going into the drug system, and then the number who come out the bottom. And what you can see is that the hit rate for many forms of drug would be a drug company might reasonably expect a 4 or 5% hit rate. In Alzheimer's disease, historically, this has been less than 1%. So there's a huge fallout rate. There are certainly several drugs which could, in theory, attack the amyloid plaques that I've talked about, the tau tangles, and other targets. But in reality, because we don't know whether they work, we're going to have to find that out by trying the drugs and seeing what happens. If amyloid is the basis of this disease, then we have several drugs which can stop or even clear amyloid. Some of them are molecules, small molecules. Some of them are immunological drugs based on the immune system or antibodies. And only when we've done trials in these drugs will we know whether this works. And it is likely the early drugs we use will be ineffective and have high side effects. But if we can demonstrate some effect to prove that this actually does improve the progression of Alzheimer's, that does give us a lot more confidence that we're going in the right direction. We haven't yet got to that point. There are other areas, but at the moment the three major drugs are things to attack amyloid, things to attack tau protein, and neuroprotective agents. And a long way behind that, some early experimentation, and could neural stem cells stop or reverse Alzheimer's disease. But I think this should be seen as very speculative. Now, in terms of modifiable risk factors for Alzheimer's, the associations are surprisingly similar to cardiovascular disease, which makes your life easier because things that are good for your heart and good for your stroke are also good for your Alzheimer's. There's a very clear association between obesity in middle life, most of us are in middle life of one form or another, and Alzheimer's later on. Less of an association between obesity and Alzheimer's in the elderly, interestingly. There seems to be reasonably good evidence, I think, that exercise reduces the chance of getting Alzheimer's subsequently and reduces the effects of Alzheimer's once people have got it. I think that evidence is reasonably strong. And there is moderate evidence that reducing or stopping smoking, improving diabetes, improving cholesterol, and alcohol only in moderation may lead to improvements in progression of Alzheimer's disease. But these ones, I think, the evidence is weaker. But since these are good things to do anyway, it's kind of a no-brainer. Prevention of dementia. In the absence of evidence, it allows anybody to go wild. All I would urge you is don't believe everything you read. I have slightly unfairly here chosen a few front pages from our friend the Daily Express. All of these things may or may not help you, but even if you did all of them, I wouldn't bet on it too strongly. There is reasonable evidence for exercise, stopping smoking, and keeping mentally active, and probably for reducing alcohol intake. But I think the thing to remember with public health is there are broadly three things we can do, and we need to learn how to do them with Alzheimer's. There's primary prevention, things we can do with everybody, where the risks are low, the whole population can do it, and it will reduce, on average, the chances of the population getting it. And things like exercise are in that group. The second thing we need to do is secondary prevention, where we identify particular people who are at greater risk and say we're going to do some things with these people which are a bit more inconvenient, have more side effects, a bit more expensive, but because they're higher risk, this is justified. And then there's tertiary prevention, which is identifying people who've already got Alzheimer's and trying then to reduce the risks of that progression. And for that, we'd probably accept a drug with quite significant side effects because they've already got the disease. Now, the reason I'm making that point is when we start to have an understanding about how to do secondary prevention, identifying people at high risk and then targeting them with interventions, it will be important to understand genetics. So a little bit about genetics and Alzheimer's. Other than rare early Alzheimer's disease, most of it is not inherited in the way that the general population understands inherited. It's not that if a mother or father has it, their children have a 50% chance of getting it themselves. But there is an association. If you have a close relative with Alzheimer's disease, your risk is roughly doubled, but from a very low base. So doubling of 1% is only 2%, for example, if you're talking about your 60s. Many genes seem to be associated, but the major one is a gene that we know about, at least, is a gene that controls apolipoprotein E, called ApoE in most things. And there are three variants of this gene, E2, which is protective, E3, which is the one that is sort of the main one, and E4, which is a risk for Alzheimer's disease. In the UK, and it varies by population, roughly 25% of the population get one E4 gene, and this leads to a slight increase in risk, and I'm going to show this graphically in the next slide. If, on the other hand, you are on the 2% of the population where you get two E4 genes, your risk goes up roughly 10 times. So this significantly increases the risk of getting slightly earlier Alzheimer's. But remember that most people with one E4 gene, and many of you in this audience may have that, will actually not get Alzheimer's in the current normal lifespan. And I don't recommend you all go out and get yourself tested, because if you don't have it, it doesn't mean you won't, and if you do have it, it doesn't mean you will. It'll just cause confusion and worry. But it will be useful when we actually get to the point we have some drugs. But genetics probably determine not whether you get Alzheimer's, but when. And the when may be at 130, in which cases, if you're worried about Alzheimer's, you have other worries on your mind. So this is a graphical representation of what we think happens with these, and I want to stress this is schematic, this isn't real data. If you have the two E4 genes, in this 2% risk, you are likely to get Alzheimer's at a much earlier stage, on average, than if you have the more protective genes elsewhere. Now, moving on, and I'll do this much more briefly, to dementia with Lewy bodies. The brain pathology of dementia with Lewy bodies is quite different from that with Alzheimer's disease when you look down a microscope. And it looks very much like the brain pathology you get in Parkinson's disease. And what it looks like is if you get the particular cell changes that you get in Parkinson's disease around the base of the brain, they're called the substantia nigra, you get the classical symptoms of Parkinson's disease all of you know about with tremor. If you get the same pathology at other parts of the brain, particularly the frontal lobe, you get this dementia with Lewy bodies. So it depends where it starts. They tend to merge into one another over many years, or over a number of years. Now, because it affects particularly the front part of the brain more than Alzheimer's disease in early disease, they may have motor features, so they may have motor problems. They also tend to have that analytical, people who've got this disease tend to have that analytical functions relatively early affected, and their memory may be affected relatively later. But two things are notable about it. One of them is, unlike Alzheimer's, it is very much fluctuates. It can fluctuate from day to day or even within a day, so people are really very lucid at one moment and not at others. And it can be associated with extremely distressing hallucinations, particularly visual hallucinations, which can be very difficult for the people who have them. The drugs which work a little bit in Alzheimer's to reduce symptoms also seem to work in this. The drugs which prevent Lewy body dementia are, in my view, likely to be different from those for Alzheimer's, and there's a much less clear association with genes. And if they get Parkinson's symptoms, you can treat that in the way you would treat Parkinson's normally. So those are the major diseases of the elderly with dementia. And as you can see, there are three major ones here in the UK, but historically there have been many more. It's important, though, to remember that treatment is not just about drugs. That's true for all of medicine, but it's particularly true in an area where we really have very few drug options. There's pretty good evidence, some of it anecdotal, some of it much more, in a sense, science or numbers-based, that doing things that stimulate people's memories and keep them remembering things, music, dance, a whole variety of other things, improve their quality of life and may indeed slow the progression of the disease. Some quite simple things like enough light and meal times which are uninterrupted can substantially improve the lives of people who've got dementia. And the danger is people sort of hurry people through, when actually that's absolutely the wrong thing to do. There is now some reasonable evidence that, at least in some people, cognitive behavioural therapy, talking therapies, actually improve some of the dementias. And it is extremely important for everybody to minimise the gap between realistic expectations of where things are and where they're heading and what's going to happen. And the gap is often a lot of the distress that individuals and their families have. One thing in particular I think is important to probably pull out is depression. Dementia can initially often be mistaken for depression, and depression can look like dementia. Some of that would be physical. There's probably an association physically between this and dementia, and some of it may just be that they've recognised that their life is closing in and they get a reactive depression to that. Treatment may help, and in some people may help a lot. So spotting depression in people who appear to have dementia or do have dementia is an important thing to do, and to see whether they could benefit from treatment. And in terms of living with mild to moderate dementia, do remember that most people who have dementia initially and may die before they get beyond this have really quite mild disease, where some of their memory and word finding is impaired, and they're less confident than they normally were, but otherwise are relatively unaffected. And we, those of us who get it, can have, in many cases, a good quality of life, provided life is adapted around the person rather than expecting them to be exactly as they were. And I think I know, and all of you will know, people who have got dementia but have a good quality of life, and for a long period of time. With more severe dementia, this is a minority of course, memory of important people, places, and their personality gradually get eroded. Very distressing to watch for people. I think one thing I would say, important to understand, anger and aggression are, as with very small children, a form of communication and should be understood in that way rather than seen as an attack on people. You don't expect the fact that a child is crying to mean that you get cross with them, and yet it's very easy with an adult. And of course, it's very important to maintain the dignity of the individual and also the dignity of their families. I do worry that historically we have forgotten dementia research. I think a depressingly large amount of what we currently know about dementia would be completely familiar to Dr. Alzheimer and to Dr. Louis, who worked together on dementia in Munich around a century ago. Historically, I would say it's a statement of almost certain fact that dementia has been under-resourced in dementia research compared to many other areas such as cancer and heart disease. But that is now beginning to change, and certainly the UK government, the Prime Minister here, have announced substantial recent investments in dementia, and that clearly is important to continue. But there are some very difficult scientific, ethical and legal challenges to research in dementia, which don't affect other diseases to the same extent. And I'll come on to them in just a second. So before I move on to just some of the more difficult areas of the future, this is really, I want to summarize what we've covered in terms of understanding the disease. We've talked a bit about the current epidemiology, the fact that this is several diseases, and many diseases have historically gone away, particularly the classical nutritional and infectious causes. We talked a bit about memory and how it works. And we talked a little bit about some rare familial dementias and the genetics of dementia, and then talked about the three big dementias of old age in the UK and the Western world: vascular dementia, Alzheimer's dementia, and dementia with Lewy bodies. To finish off, just a few projections to the future, which are about policy or dilemmas I think we have as a society. If you look at dementia prevalence, how common it is in the UK, and I've chosen England here, it is not evenly distributed across the country. It is, in fact, quite highly concentrated in those areas where elderly people currently live, unsurprisingly. This is going to get worse over the next 20 years. And that is because cities import youth and export age, and elderly people go to live somewhere else, and they tend to concentrate in particular places. So I'm contrasting here, and this is referring back to a talk on demography I gave a year ago, on comparing the City of London, where the big group of people who live in the City of London, here where we have this lecture, are young adults, dementia extraordinarily rare in this group. But if you went to a town like Chichester, for example, huge numbers of people who are on the age group and are going to get into the age group where dementia is going to happen. So in this country and in many other countries, where people are with dementia is going to heavily concentrate in rural or semi-rural areas where services are often more difficult to provide. And if you project forward, this is just looking at the UK, roughly when I qualified in medicine, around now, and what's going to happen when I roughly retire. When I qualified in medicine, almost nowhere in the UK had more than 2% of the population over the age of 85. Now, if you look, this is quite widespread, and there are certain areas of the population, particularly around the south coast, and the same would be true in most wealthy countries, where there are now significant concentrations of older people. But if you project forward to the point when I and many people in the audience retire, very large parts of the country, including quite rural areas, are going to have very high proportions of the population in the age group where dementia is much more common, that is where the disease will concentrate. That is a serious policy problem, which I do not think we have yet fully got on top of. And then there are some ethical and legal issues which are very specific to dementia. The first one is, we talked about the fact we need to do research and we really need to improve this. Central to doing trials in adults is the idea that you should expect them to be able to give consent for trials. No one can give consent for an adult in British law, and yet people who have dementia are unable to give consent in British law. This is a serious problem for us, people who've got advanced dementia. The theory of protecting people so that vulnerable people can't give consent to trials is great, but the practical implications of a ratcheting up of the expected ethical standards are we are increasingly excluding elderly people from trials where they're the ones who are most likely to benefit. This is a very serious, in my view, problem that I think people have not really thought through. And I do not, in my own view, think that the law of consent in the UK is future-proof for a situation where a much larger proportion of the population will have dementia, which does not allow them to consent according to current understandings of what allows you to consent. I think there are also ethical issues associated with the fact we have professionalised the care of dementia in elderly care homes. So if you go to a residential home, whereas in the general population dementia is actually quite rare, in a residential home typically around 60% of people will have some degree of dementia, and in a nursing home over 70% will have dementia. And people find it very difficult to make difficult ethical choices for people for whom they are professionally caring rather than who are family. For example, should people repeatedly be given life-saving antibiotic treatments when they are not able to understand what is being done for them and have lost their dignity? It's very difficult for people who are professionals to make that judgment which might have otherwise been made in family settings. So these kind of issues, I think, are going to increase in our society, and I think we need to face them straight on rather than trying to dodge them, which I do sometimes feel we do. So to summarise, for dementia in older age, our worst times are ahead of us because of the ageing of the population, but I am absolutely confident that our best times are also ahead of us. The classical infectious and nutritional causes of dementia are largely gone from high-income countries and are now going from almost all the remainder. The incidence of dementia looks as if it is falling in high-income countries, especially in men, and my own view is that's probably driven largely by vascular dementia. It is likely that vascular dementia has retreated and will continue to retreat in much the way that stroke and heart disease have. This is good news, that for Alzheimer's dementia and dementia with Lewy bodies, we're not going to turn that tide until we better understand what to do about it, and that does involve, in the case of these dementias, a better understanding of the science. And to be clear, just a 5-year reduction in when people get dementia would probably reduce the prevalence in the population by about 50%. So we should be aiming not to cure dementia, but to delay dementia and to make it possible to live with in the way it is now possible to live with things like diabetes, to live with many cancers, to live with HIV. And this seems to me an entirely realistic target. This is a matter of when, not if. Thank you very much.